Hello.
Hello.
Yeah, hello. My name is Dr. San, doctor from this department. I assume I'm wearing universal precautions. Uh, I can see the patient is lying on the bed. The respiratory rate is 25 per minute, oxygen saturation 88% in room A, heart rate 118, blood pressure 110/70, temperature is 37, and ECG show atrial fibrillation. Since my patient has got reduced oxygen saturation, does he have any smoker cough?
No.
Okay, then I want to give my patient 100% oxygen, 15 liters per minute via the non-vibrator mask. Okay. Can I confirm your name and age, please? Hello. Yeah, can I confirm your name and age, please?
I'm John, doctor.
Okay, John. So can you tell me what's happening to you?
I can't breathe, doctor.
Okay, so okay, yeah. So I've now given you the oxygen, and I will also. Okay, so how are you feeling now?
Yeah, doctor, it's better.
Okay, so can you please tell me what? Okay, oxygen saturation is now 90%. Respiratory rate is 20. Okay, and then okay, John. Now let me quickly assess your chest so that I need to expose you. Would that be fine? I will have a chaperone with me throughout the examination to ensure your privacy.
Okay, doctor.
Okay, so and on the chest examination, I want to look for the trachea and also the inspection, the chest wall movement, symmetry or not. And on the palpation, I would like to do for chest wall expansion and on also the percussion on 3 zones on both sides and auscultation.
Okay, so on auscultation, there is crepes, bilateral crepes.
Okay, yes. Okay, now my patient got the bilateral crepitation on both sides of the lungs. And now, John, now I would like to check for the circulation. So I want to go for the periphery to check whether there is any cold periphery spot. Capillary refill time, pulse is 118, is on the higher side, and blood pressure is 110/70. So I would like to insert one large bore cannula, and at the same time, I would like to withdraw some blood for routine investigations like the full blood count, liver function test, kidney function test, and cardiac enzymes level. And yes. Okay. Okay, and I also want to check for the whole body to know whether there is any bleeding on from side, and also okay. And since my patient is talking, his GCS is he is oriented. So John, can you please squeeze my hand?
Yes, doctor. GCS
okay.
is 15 by 15.
Okay, GCS is 15 by 15, and I would like to do the head-to-toe examination to know whether there is any on the legs, to know whether there is leg swelling or inflammation. Okay, and John, so yeah, so can you please okay,
there is swelling. There is swelling on both the ankles, pedal edema.
Pedal edema. Okay, my patient has got pedal edema on both sides, and the ECG showed the atrial fibrillation, and I also heard the crackles from the when I checked the length. Therefore, I want to give my patient IV furosemide 40 milligram. Okay, so John, can you please tell me what had happened to you?
Doctor, I was not able to breathe.
Okay, John, yeah, I can see. Yeah, John, now I've given you the oxygen and also given you some medications to relieve your symptoms. So how are you now?
Yeah, I'm better.
Okay, so you feel that you cannot breathe. So how long have you been having that?
For 2 days, doctor.
Okay, so is it getting worse?
Yeah, it was getting worse, doctor.
Okay, is it off and on or it's always with you?
Yeah, it is always there.
Okay, so have you tried something for your difficulty in breathing?
No,
Okay, so along with that, do you have any other symptoms?
no,
Okay, and do you have any cough?
no,
Any swelling around your legs?
no,
Any tummy pain?
no,
Okay, and so by any chance, do you have any fever or flu-like symptoms during these days?
no.
Okay, so do you have any previous medical condition that I should be aware of?
Yes, doctor, I'm having some problem with my heart.
Okay, so have you ever had any hospitalization for your heart problem?
No,
Okay, so are you taking any regular medications?
no,
Okay, and so along with the heart problem, do you have any other problem like high blood pressure or high blood sugar?
no,
Okay, so any family history of any medical diseases?
no.
Okay, and I also want to ask a few questions relating your lifestyle. So may I know, do you smoke?
Yes, doctor.
Okay, so can you tell me more about it?
Yes, doctor, I'm smoking 10 cigarettes a day. Okay, time's up. Okay,
Okay.
so Dr. San, good attempt, good attempt. Apart from the
Yeah,
opening and few other things that I would like to mention. So
yeah.
in Simman as well, in data gathering stations as well, in all kind of stations, combined station as well. So just to reinforce this thing, after 6 minute bell, what you have to do, you need to talk
No,
about the management, right?
yes.
So in the management, you were gathering data. Yeah, that was fine. But after your data gathering, when you were suspecting your time is going to be finished soon, so you need to talk about management. You need to tell that person what was going on with him, right?
Okay. Yes.
So, okay. So the problem that there was another problem in that station as well. So first of all, I would like to ask from Dr. Mariam. Dr. Mariam, can you please tell me what things she has missed?
No, actually, she approached very well, and like she was addressing the patient's vital very well. But yes, in this beginning, she didn't ask to the patient that he reply like, is he okay, and what is the main problem with him. That what I can say that about that. And secondly, yeah, if the I don't know about this, that if the cause of AF, so we were not reached to that point, that what was the cause of AF, so hence the management was left, that I think I should that should
Yeah.
be mentioned here.
Okay. Yeah. Good. Anyone else want to add anything here? All right. So, Dr. San, very well done.
Yes.
There are few things that I would like to add, and also for everyone, they are going to help everyone, not here in this PLAB 2 exam, but also in your interview as well, because in your interviews you're also getting a clinical scenario, and they're expecting you to do A to E approach in order to solve that scenario. Okay. So let's start from the beginning. When you went inside the cubicle and you saw the patient, he was Simman, right? So
Yeah.
Simman is not a machine. You have to assume that he is a patient. So can you read your task here? Please talk to the patient, assess him, and manage him.
Yes.
So when you went inside, you said my patient is lying on the bed, and the vitals are respiratory rate this, SpO2 this, heart rate this, and you did not talk to your patient in the beginning. Later on, in the middle of the station, like after doing your A to E, you started talking to me, right?
Yes, I forgot to talk to the Simman.
Yes. So the thing is that when you go inside the Simman cubicle, you will go and you will greet him like the normal patients. It is a Simman, but it is a kind of mannequin, right? So whatever we are doing with the patient, we are going inside, we are greeting them, we are talking to them, and then we are going to, first of all, we will try to get some data depending on the patient situation. But since this is an emergency, sorry. Okay, so let's start. Like when you go inside, just go and say hi. What was the name? Hi, Mr. David. Hi, David. How are you? So he will say, doctor, I can't breathe. So David, you know the age of the patient. So yeah, you can skip that. And then you can say, David, I'm really sorry for that. I will try to talk to you if you are comfortable. So are you comfortable to talk, David? He can say yes, he can say no. If he's saying yes, then you can ask a little bit audipara about shortness of breath, right? No need to go in so much detail. Just try to get a little bit audipara. You are having some clues in your task as well, that this patient is hypertensive, this patient is having ischemic heart disease. Keep these things in your mind. If your patient is not talking to you, case is very simple. What you will do here? You will start doing your A to E approach. So if your patient is answering you, but he's saying, I'm not comfortable to talk, then what you will do? So since my patient, okay, John, okay, David, don't ignore the patient. Try, keep talking to him. Okay, David, I'm going to assess you from head to toe. And while doing that, I will try to make you comfortable. I will be doing some examination as well at some point. And for that purpose, I need to expose you. Don't worry, I will be having a chaperone with me. Can I proceed, David? You have got the consent now. You have explained him what you are going to do. You have told him the purpose. You have got the consent. You have mentioned the chaperone. And now start your A to E approach. So since my patient is talking, since David, you are talking, so your airway seems to be patent. Now I'm going to quickly assess your breathing. So while you are doing your breathing, circulation, and D part and E part, what you have to do? First, comment on the things you can see on the monitor. When you are talking about your B part, so what are the things that are related to B part? SpO2 level and respiratory rate, right? So comment on that. I can see your saturation, oxygen saturation is 90%, and your initially it was 88%. Okay, so and your breathing rate is 25, David. So are you having any smoker's cough? No. So I will quickly attach oxygen. Tell, okay, it is very important to tell the units of the medication, whatever you are doing in Simman. If you are not saying the doses and saying it completely, then you will lose marks. So what is the dose of oxygen? Can somebody tell me?
15 liters per minute, high flow oxygen.
Yeah, correct, correct. So you will attach this patient with the oxygen, 15 liter of oxygen per minute, 100% oxygen. And how are you now, David? If he's saying, yeah, I am better, and if you are seeing significant improvement on the monitor, like if initially it was 88 and now it is 95, respiratory rate is 20, significant improvement, then okay, you can go on and you can start talking about his data gathering. If there is no significant improvement, then go to the next step. So after you have checked the SpO2 respiratory rate, now you have tried to fix SpO2. Now what will you do? You will see the breathing what is the problem with the breathing right now. So what you will do, you will inspect the chest now. So tell him, now I'm going to check your breathing and I'm going to expose your chest. David, I'm having chaperone with me. So I'm going to check that. I'm going to inspect the chest for any for any unequal chest movements. And then I'm going to listen to your breath sounds. And while you are listening to the breath sound, I gave you a finding here that there are bilateral fine creps, so or crackles. So if you are finding creps in the chest, then what are your 2 DDs? Can somebody tell me?
Heart failure and sepsis, I think.
Yeah, perfect. So now what these 2 things are in your mind when you saw the creps in the chest. If there was V's, then your DDs will be different, right? you will be thinking in different dimensions. So keep these things in your mind and try to get some more clues. No, now move to the C part. In C part, again, comment on the things that you are able to see on the monitor first. So I can see on the monitor your heart rate is, initial heart rate was 118 and blood pressure is 110/70. And your ECG is showing some rhythm problem. So I will quickly examine your pulses now, David. And what you have to do here, you have to check the pulses, you have to check the peripheries, you have to check the cyanosis, you have to check the capillary refill time. So don't you think when you are checking the peripheries, you are checking all 4 of them? And if there is pedal edema, you can get finding here in C part. What do you think? Please say yes or no.
Yes, yes, of course. We can see that swelling is there.
Yeah. So if pedal swelling is there, patient is having AFib, patient is having PREPs, patient is having blood pressure, high blood pressure was not a problem, heart rate was high and respiratory rate was high, SpO2 was low. So all these things are showing he might be having heart failure, right?
Yeah.
Yes.
You will pass to wide bore IV cannulas. You will take bloods from the patient. Don't forget the ABGs. Don't forget 12 lead ECG. And then you will start the management, this management here. Wherever you are going to find the problem in Simman, you are going to treat there and then. If you have found the problem in B part, for example, it was asthma station and you have found V's. So you will give him salbutamol there and then. And you will keep giving him treatment until your patient is stabilized. You give salbutamol, then you go to the next step, then next step, then next step, until your patient is stabilized. In the same way, here you will give your patient IV diuretics, 40 to 120 mg, furosemide, say the dose, and then since this patient is having heart failure, so we have to monitor the blood pressure reading and we have to give the fluid with caution. If BP is normal, then right now fluid is not needed. So don't say, normally when we are going in a flow, we can say we will start him on IV fluids. So don't say that. This is a heart failure. And then we need to give diamorphine as well to this patient, 1 milligram up to 5 milligram. He might be having some chest pain. If not chest pain, still we will be giving this diamorphine. It is a treatment of heart failure because it has something to do with the parasympathetic nervous system. Then we are going to, if patient is complaining of any other problem like maybe nausea, then we will going to do the antiemetic as well. And this patient is, these things, give the fluid, talk about IV diuretic right now, and then you can move to your D part and you can move to your E part. And then at the end, when you are summarizing the whole management, then you can talk about all these things together. Okay? Urine input output monitoring you can mention in C part as well. When you have finished your A to E, then you can mention about rate control, then you can mention about senior involvement, then you can mention about giving diamorphine, antiemetic if patient is feeling nauseous. In the D part, after C part, after giving the diuretic, what you will do in the D part, you will check for the temperature, you will check for the GCS. Basically, in A to E approach, we are going to see AVPU score. A is for alert, V is for responding to verbal stimuli, P is for painful stimuli, and U is unresponsive. So use this. This is a short way of checking the neurological status of the patient. This patient was alert. And then you will quickly go in the E part and you will examine him from head to toe. So whenever you feel like your monitor is showing good readings and it is improving, at that point, after giving, and at that point, or after you have given him diuretic, for example, and you asked him, how are you now, David? He said, better, doctor. So you can ask him, so now you can talk, David? Can you manage? So then start gathering some data about shortness of breath, about a little bit past medical history. And then wait for the 6-minute bell. As long as you are hearing 6-minute bell, you can gather the data. But when you will hear the 6-minute bell, start your talking about the management to the David. Tell him what's wrong with him. Tell him what you have done so far and what you will do in the future. Don't forget the AFib part here. Is it clear? Any question?
Dr. Korat, you mentioned that when we, in the breathing part, when we auscultate the patient, we already hear crackles. So don't we start management then? Or we move on to circulation and then start with furosemide?
Well, in the breathing part, only crackles can be because of other reasons as well, right?
Yeah.
So try to get some clues. In the C part, you can get some ankle edema. You can get some signs of fluid overload, right? If
Yeah.
not, no signs of fluid overload, then still in the C part, how you are going to start him on diuretic if patient is not having IV access. You are going to establish IV access in C part, right?
Yeah. Okay. Makes sense. Yeah.
So
Thank you.
after that, now heart failure will be your DD because patient is having MI, patient is having high blood pressure. And in the meantime, if you can get some data and you can gather some clues, that is well and good. Otherwise, depending on the examination finding, depending on the history finding, a topmost DD would be heart failure in this patient. But don't make a blind diagnosis, okay? It can be a PE, shortness of breath, patient unstable, PE. We are always thinking about PE. But if there are clues which are going in favor of this heart failure, then obviously you will think about heart failure. If there are some clues which are going in favor of sepsis, then you are going to treat him on sepsis line. Is it clear now?
Yes.
Yes.
I hope now you will be able to do Simman in your exam. So these are the same things that I have discussed with you. If you want to take pictures, then you can do that. I have also shared a picture in the group as well about this heart failure management.